everyone. This is Melody Coomer. I have selected dialectical behavior therapy and borderline personality disorder. So, DBT was developed by Marcia M. Linehan, PhD, to address the suicidal tendencies of individuals and was first validated with suicidal women who were diagnosed with borderline personality disorder. Because individuals with BPD often are associated with the revolving door of treatment facilities, Dr. Linehan sought out a means to better accommodate the needs of those with BPD who seem to need specialized therapy. DBT pulls from other theories including psychodynamic, Gestalt, client-centered, and paradoxical, but also applies aspects from behavior science, mindfulness, and dialectical philosophy. It's important for the therapist to acknowledge and promote the client's valid responses, because in combination with DBT, this is what actually facilitates change. So the quotation here is, DBT case conceptualization is based on biosocial theory and level of disorder. At Peakview Behavioral Health, the agency that I am doing my internship at, DBT is practiced on the outpatient unit. So I spoke to my supervisor, her name is Vicky Sanchez, and she states the pros of DBT include that it is structured and it provides skill building, and the cons include that it is structured and that because the clients have a lot of assignments to complete, if they are not completed, they can be quote-unquote fired. So biosocial theory, Linehan states with BPD it is a pervasive problem with the emotion regulation system. And as far as level of disorder, selecting the most vulnerable clients, for example, suicide attempts, homelessness, drug abuse, out of control anger, selecting these most vulnerable clients takes precedent. We should follow DBT's stage model of treatment. So, stage 1 is pre-treatment. The client and the therapist agree to goals and methods of treatment. The goals are set up and addressed in order of importance. So number 1, suicidal, homicidal behavior. Number 2, therapy interfering behavior by the therapist or the client. And number 3, behavior that severely impacts the client's life. And number 4, deficits in behavioral capabilities needed to make life changes. Stage 2, the goals of therapy are to have non-traumatizing emotional experiences and connection to the environment. Stage 3, the patient combines what they have learned into a coherent whole, demonstrates a respect for oneself, and independently solves their own problems. And then also a review of the same issues from a different vantage point. Stage 4 focuses on the things that have not been completed through treatment, even though solving personal problems has been resolved. Goals are outside of the traditional therapy and focuses on spiritual fulfillment, joy, and freedom. So some of the things that I believe my classmates need to know include that borderline personality disorder patients are very difficult to treat. The patients experience emotional problems and abandonment concerns, along with the inability to cope with the smallest of pressures. They also experience consistent crises, commands, and the roller coaster ride of emotions, which can take a toll on the counselor. It's easy for the patient to think the counselor does not care, and often the therapist and the client arrive to the conclusion it is a hopeless cause. Just on a side note, I want to say that DBT therapy seems to be a very incredible intervention, and I believe it gives hope to many of a BPD patient. So I just want you all to know that, even though borderline personality is one of those taboo illnesses, that the chances of a person coming out on the other end is actually very likely, instead of the perceived thought that they're just going to continue the same path and live their difficult lifestyle. So DBT provides that much needed hope, providing validation, coping skills, and emphasizing boundary setting between the clinician and the patient. So again, research has shown the validity of DBT. The question was, what diagnostic criteria are used to diagnose the disorder? I didn't really follow the DSM-5. I just kind of came up with separate statements. So the criteria that are used means unstable self-image with excessive self-criticism, thoughts of emptiness, dissociation under stress, instability in life skills like work, education, values, and pursuits, as well as lack of empathy and intimacy. So the DSM-5 would probably mention something to the effect of these individuals have pervasive patterns of unstable relationships, that they have fears of abandonment. So just to name a few of those that would be found in the DSM-5. What are the recommended interventions and tools for my chosen theory? In standard DBT, it takes 24 weeks to get through the full skills curriculum. It is best to use the DBT skills training manual and accompanying patient workbook. So I wrote down just a few examples or tools that you would want to use. Include distress tolerance skills, the wise mind versus the emotional mind versus the reasonable mind, and mindfulness skills as well. And I believe the reason why my chosen intervention, dialectical behavior therapy, is recommended for borderline personality disorder. The patient populations for which DBT has the most empirical support include parasuicidal women with borderline personality disorder, but there have been promising findings for patients with BPD and substance use disorders, persons who meet criteria for binge eating disorder, and depressed elderly patients. So again, the empirical support includes suicidal women with BPD, and so that's why I chose DBT. Now we were supposed to role play an ideal client versus a non-ideal client. I wasn't sure how we were to do this, so I just said some things that a non-ideal client might say. not necessarily during a therapeutic session, but so in an episode they might say something like, "It's my property. You don't give a fucking shit about it, do you? Well, I don't give a shit about your fucking property." Sorry. I just want people to understand. Okay, so the ideal client would be saying something like, "I just want people to understand what I am going through. Everything that is criteria for borderline personality disorder matches up to my symptoms." So this particular person has actually acknowledged that they are experiencing these things, and they do actually believe that they do have BPD, and then I think that this is the next step into, this individual deciding to educate other people on, because she wants people to understand what she's going through, and so therefore educate these individuals. Okay, the next question, are there any considerations relating to gender, culture, and ethnic issues? Women reported more success with the the DBT intervention than men. And then also the therapy was created in the United States for a certain population. So adaptations are necessary to work with different ethnicities and cultures. And in fact, they've already done this with DBT. They have tailored therapies for other countries like Nepal. I saw that as I was researching. The next question, are there any ethical and philosophical conflicts, issues affecting the assessment and intervention process of this disorder? So, dialectical behavior therapy is a complex treatment that requires the counselor to master a number of strategies and skills in addition to standard cognitive behavior therapy techniques. It requires, therefore, much intensive and extensive training and supervision. So, this kind of scares me. So I feel like I need to be really experienced in DBT before I decide to practice it. Should we, and then in addition to that, my questions were, should we tell them what their assessment says? What should we tell them about their suicide risk? Should we be available by phone? When should we put them on an M1 hold? How do we handle things if they return to treatment after an attempted suicide? So that pretty much covers my presentation. I guess it's not 20 minutes long. I could drag it out if you want me to, but I won't. Okay, good talking to you guys. Hope you enjoyed this broadcast.